And we are live again, I hope. I think people will be joining Whova or Zoom directly right now. I just want to let you know that in the description of this track, everybody who's attending, we've also posted the direct Zoom link because the quality of the video especially isn't always that great if you watch the tracks through Whova. So you can also use the Zoom direct link. And I'll hand it over to one of my supervisors and colleagues at the University Medical Center in Groningen, Robert Schroevers, who's a professor of psychiatry and the head of the Department of Psychiatry there, and who will be chairing the session that we have now until 1 o'clock exactly. So Robert, the floor is yours.
Thank you very much, Joost, and welcome everybody to this session. We have three very interesting speakers who will reflect on different aspects of psychedelic treatment. And after that, we will have a panel discussion. So to the audience, I would like to say, please send your questions through the app. And then we will have time, the speakers will have time to address them between 12:15 and 13 hours, so 1 p.m. I will announce the three speakers. The first one will be pre-recorded and hand it over to them to tell you all kinds of interesting facts and findings on their topic. The first speaker is Katrien Preller. She has a master in neuropsychology and clinical psychology. She investigated the neurobiological and social cognitive effects of cocaine, MDMA, and heroin use. And she is now involved in the psilocybin trial, the second psilocybin trial that runs in London. And she has a pre-recorded session. She wasn't able to join in the Congress. And Floris, could you please start the presentation?
Hello, I'm Katrien Preller, and I'm very happy to talk about the neurobiology and pharmacology of LSD and psilocybin today. Psilocybin, the main active compound of the so-called magic mushrooms, and LSD are both serotonin agonists. They induce pretty similar subjective effects. However, the pharmacology is slightly different. Psilocybin is a preferential serotonin 2A and 1A agonist, so it's pretty specific for those receptors. LSD, on the other hand, has a very diverse pharmacology. It stimulates various serotonin as well as dopamine receptors. Before I dive into the studies that we have conducted with these two substances, I want to spend a little bit of time to talk about these substances in general. So psilocybin as well as LSD are usually considered to be on the lower end of harm potential of psychoactive substances. And there are two reasons for that. First of all, they are not addictive. And the second reason is that usually it is very hard to overdose on these substances. That does not mean that taking a heroic dose of LSD or magic mushrooms is necessarily a good idea, quite the contrary. However, it is really hard to kill yourself with these substances, which is obviously very different from the substances like alcohol or heroin, which are on the higher end of the spectrum. But that doesn't mean that we do not need to be careful when we're conducting these studies. So for our participants, we, for example, screen for any first-degree relatives which may be suffering from psychosis, for example. We also screen for heart diseases and make sure that our participants are healthy mentally as well as physically when they enter the study. So what do these substances do? What do people experience? So let's consider this picture of a wolf here. What might happen is that the colors may appear brighter, colors might change completely, things might start to get blurry. And what happens most of the time at the doses that we administer is that things might start to move around. So here we're talking mainly about illusions at these doses, not necessarily true hallucinations. But of course, these visual effects are only one part of the spectrum that these substances can induce. So what we see additionally to alterations in visual perception, this one here is LSD, this one here is psilocybin, is alterations in how we perceive ourselves and how we perceive our environment. For example, experience of unity, insightfulness, disembodiment. These are all things that participants report very often under the influence of these substances. And we think that some of these effects may be beneficial also in clinical populations. And there have been quite a few studies using psychedelics to treat mood and addiction disorders recently. However, that is not what I'm going to talk about today necessarily. I am going to talk about the studies we conducted with healthy participants. And the reason for that is that, first of all, psychedelics offer this unique opportunity to study relevant phenomena that we otherwise cannot really study. For example, studying the neurobiology of alterations in how we perceive ourselves, for example. This is really hard to induce otherwise, and psychedelics here open the window to look into the neurobiology of these phenomena. And on the other hand, it is important to increase our mechanistic and pharmacological understanding of these substances to uncover their full clinical potential. So the two questions I'm going to tackle today are, what is the pharmacology and neurobiology of psychedelics? And what may be the potential therapeutic effects of psychedelics? So I'm going back a little bit to the pharmacology of LSD. What I said in the beginning is that the pharmacology of LSD is pretty complicated and diverse. It is stimulating various serotonin as well as dopamine receptors. So if we want to understand what LSD is doing at a receptor level, we had to use a second substance, which is catenzerin. And catenzerin is pretty specific for the serotonin 2A receptor. It's a serotonin 2A receptor antagonist. So it blocks this receptor. And then when we administer LSD afterwards, it can target all the other receptors, but not the serotonin 2A receptor, which means we can see which kind of effects are left after the serotonin 2A receptor is blocked. And when we look at the subjective effects, we can instantly see that basically no subjective effects, at least at the dose, we used 100 microgram LSD here, no subjective effects are left when the serotonin 2A receptor is blocked. So you see in these pink bars here, the effects of LSD, which is basically what you would imagine. And then what you see here in green are the placebo effects, so very little placebo effects. And in yellow, you see the catenzerin plus LSD condition. So all the effects induced by LSD are reduced to a placebo level when we pre-administer catenzerin. And this also holds true when we look at the effects over time. Now, I want to take a look into the brain connectivity measures. So what do psychedelics do on a neuronal level? And the first hypothesis that we tested here was the so-called thalamic filter model. So one hypothesis about how psychedelics act in the brain is that they change how the thalamus filters the information to the cortex. So specifically, the thalamic filter model states that the thalamus is filtering less information from our environment, which leads to a sensory overload, and this is causing the psychedelic symptoms that our participants are experiencing. The way we test it is to use a technique that is called dynamic causal modeling. And Dynamic causal modeling gives us the opportunity to look at directed connectivity between different brain areas. So of course, we looked at the thalamus, which is key in the thalamic filter model, and looked at connectivity to the ventral striatum, as well as two cortical brain areas, the posterior cingulate cortex, as well as the temporal cortex. And what we saw here is that there is indeed increased connectivity from the thalamus to the posterior cingulate cortex. However, there's also decreased connectivity from the thalamus to our other cortical brain area, the temporal cortex. So it seems like the thalamus is not just sending information to the brain in an undifferentiated way, but it is sending more information to very specific parts of the brain, as seen here with the posterior cingulate cortex, which is an important area for self-perception. But with dynamic causal modeling, we can, for the time being, not look at the whole brain. So we took another functional connectivity approach to look at whole brain connectivity maps. The approach we used here is a data-driven approach called global brain connectivity, which shows the connectivity of each brain area with the rest of the brain. And what you can see here in warm colors is increased connectivity under the influence of LSD. And what you see in blue colors or cool colors is decreased connectivity under the influence of LSD. And you can easily see that two networks emerge. So we see increased connectivity in sensory brain areas of the while at the same time we see decreased connectivity in brain areas which are responsible for integrating this sensory information to give us a coherent picture of our environment and ourselves. So it seems like we're talking about a state of increased sensory perception and processing, and at the same time we might lack the ability to integrate this information in the usual way. And this may explain why we perceive the world and ourselves differently under the influence of psychedelics. Now, coming back to the pharmacology, what you can see here, again, in green placebo, in pink LSD, and in yellow catanserin plus LSD, we see that these LSD-induced effects are again completely blocked when we pre-administer catanserin plus LSD. And the reason why I'm not showing the direct comparison between placebo and catanserin plus LSD is because you would be looking at just a gray brain. So there are no significant differences when we're looking at placebo and catanserin plus LSD in these functional connectivity measures. We also repeated the study with psilocybin, and what you can see here easily is that the effects of LSD and psilocybin are very, very similar. So both psychedelics induce this increased connectivity between sensory brain areas and the decreased connectivity in associative brain regions. We also looked at the effects over time. So what you see here is a first measurement 20 minutes after administration. This one is 40 minutes after administration and 70 minutes after administration. And you can see here that the effects increase in a more or less linear fashion. So we see the first alterations happening in our visual cortex, and then over time we see that these decreases in connectivity and the associative brain region starts to emerge. And this is very much aligned with what our participants report. Usually the first effects that our participants notice is changes in their visual environment until about 70 minutes after administration. Usually you see the full pattern of psychedelic effects. We also tested how the magnitude of induced effects relates to the baseline connectivity of our participants. And here we saw a strong relationship between the connectivity measures during placebo or baseline and the induced effects of psilocybin. And what that means is that we may have a predictive measure from the baseline state to the magnitude of induced effects of a psychedelic, which potentially could be useful in a therapeutic framework to predict which participants react how strongly to the substance we are administering. So to summarize, what we've seen is, first of all, that the thalamus is sending more information to specific parts of the cortex, in particular sensory brain regions. So we have this state of increased sensory processing, while at the same time we see disintegration in our associative brain regions. So the capacity to integrate these sensory experiences seems to be different under the influence of psychedelics, which on the one hand could explain why we see these visual alterations, for example. But this state could also be helpful to break ruminative thinking patterns, as for example seen in depressed patients, because it may force us to see the world and ourselves in a very new way. So to sum this up, we've seen that LSD-induced subjective and neuronal effects both depend strongly on the serotonin 2A receptor. We've seen alterations in effective or directed connectivity in LSD-induced states are at least partially in line with the thalamic filter model. We've seen that both LSD as well as psilocybin induce increased connectivity in sensory networks, and at the same time induce integration in associative regions. And we've seen that baseline global brain connectivity may be a predictive marker of psychedelic-induced effects. So I want to go one step further and talk about psychedelic-induced effects on social cognition. And the reason for this is that social cognition is something, or alterations in social cognition is something that we see in basically all psychiatric disorders. So we see a lot of social withdrawal, for example, or sensitivities to social rejection in patients suffering from, for example, borderline disorder, depression. And we currently do not have any medication to treat these effects. And MDMA as well as psychedelics have been shown to be very strong modulators of social cognition. So we've seen increases in empathy, we've seen decreases of social rejection sensitivity, and we've seen increases in altruistic behavior. And that might be very interesting when we're thinking, for example, about reconnecting with social environment or therapist-patient relationship. So these social effects of psychedelics on social cognition might be very important in the framework of psychedelic-assisted therapy. So what kind of insights do these studies offer when we're talking about potential clinical mechanism of these substances? Well, we have various hypotheses why these substances may be beneficial in patients. And one hypothesis is that they may change the serotonin 2A receptor system. Preclinical animal studies have also shown that they induce neuroplasticity, which, when in a framework where we can direct this neuroplasticity, may be helpful for patients and may explain the long-lasting effects of these substances. We've seen that they induce alterations in brain networks, so they might be able to normalize dysfunctional networks in the brain. We've also shown alterations in reward and emotion processing, especially in depression. We hope that psychedelics may be able to reduce the negative bias that we've seen in these patients. Also, patients as well as healthy participants report insight into dysfunctional behavior. And we've seen these effects on social connectedness, which might be very helpful. Most of these hypotheses are derived from either work in animals or work in healthy participants. So we still need to test these hypotheses in clinical populations, which is happening right now. For example, 2 studies we're conducting in Zurich right now, one with depressed patients, one with patients suffering from alcohol addiction, which will hopefully offer some insight into the mechanisms why these substances seem to be helpful in these patient populations. And with that, I want to thank you very much for your attention, and I'm very much looking forward to the Q&A session afterwards.
Thank you very much, Katrien, for your very interesting pre-recorded and very clear session. And I'm glad that you will be joining for the discussion. I'd like to announce the next speaker, which is Peter Gasser. Peter is, I think, one of the colleagues who has most experience with psychedelic therapy. He is a physician trained in psychiatry and psychotherapy. He works in a private practice in Switzerland, and he is trained in both psychodynamic psychotherapy and in therapy with mind-altering drugs. And he has been president and pioneer of the Swiss Medical Society for Psycholytic Therapy since 1996. He has conducted randomized controlled trials with patients with end-of-life related problems or life-threatening diseases. And he also treats patients in his own practice according to compassionate use rules. And I also know him as a compassionate teacher to young therapists in these kind of applications. So it is a great honor to welcome you, Peter, to this session. The floor is yours.
That everyone can hear me. I am aware that I am presenting now in front of...
Peter, we cannot yet hear you. I'm sorry. Floris, is the signal?
Peter, the sound is a bit low, but you are not muted. So we could hear you, but not too loudly. The sound is still quite far away. Yes, so yeah, your microphone was far away from your mouth. It should work now.
I guess who are interested maybe to get trained or who are interested in the method we are working with. I will show you a few slides about what we do and what has done in Switzerland.
And Peter, I'm sorry, but I still have trouble hearing what you say. Is that also for you, Joost and Floris?
Yes, it's a bit better, but still quite soft. So you could maybe put the microphone that's in your earbuds maybe a bit closer, because hopefully it is using that microphone.
No.
So maybe your computer switch to using another microphone.
Yeah.
So you can see it on the bottom left. You see the microphone, and there you can click on it, and there you can choose which one it's using.
This one?
Yes, perfect.
Is that better?
Yes,
Okay.
it's perfect. You can continue.
No, I will continue. Okay, let me try. So now it's okay now?
Perfect.
Yes.
Good.
Yes, perfect.
So again, my presentation will be about what we have done in Switzerland the last almost 70 years, and especially what we are doing now, research and psychedelic therapy, so-called compassionate use therapy. Here on the first slide, I like these two mandalas. I call them mandala. On the left-hand side is about that, what Katrien Peller presented before, this connectome, a diagram that intuitively shows that the connectivity in the brain areas are enhanced. So the areas are talking together in some ways. On the right-hand side, you see a mandala that was painted by a patient of mine after a very long therapy. She was severely sexually abused, and towards the end of the therapy, she has painted this. And this mandala, in my opinion, also shows enhanced connectivity to herself and to the world. And in Switzerland, we have a long tradition of making therapy with mind-altering substances. The first study was made in 1947 by Stoll and collaborators. It was the first clinical trial with LSD. And in our days, there are studies going on in Zurich and also in Basel with Matthias Liechti and his group. And this diagram shows only what has been done in therapy, not the basic research that has done by Vollenweider and collaborators since the 1990s, which was a very important work in Switzerland and all over the world, is not shown here. Because time is short, I want to talk a little bit about what we have done in Switzerland since 2014. After my first study with LSD, End of Life, which was then published in 2014, we got individual permission from the Swiss Ministry of Health for doing psychotherapeutic work outside of research projects. We call that restricted medical use with LSD and MDMA. It's also called compassionate use. Compassionate use comes from oncology. I mean, it's the therapy of the last hope. Here, that is not appropriate totally, but however, it is called compassionate use. I will talk you a little bit about this. The great advantage of this compassionate use treatment program is that we can just get information and experiences with new indications, not only with end-of-life anxiety, not only with depression, but we can get information for patients who suffer from obsessive compulsive disorders, from LSD, with post-traumatic stress disorders. So all kinds of indications which are mostly based on psychotherapeutic approaches and psychotherapeutic reflections, which we share to the Ministry of Health. And if they agree with us, they give us the permission to do this and that treatments. And I have 6 slides with treatment principles I would like to share with you, because there's a difficult question. What kind of therapy are we doing when we use these mind-altering substances? Is this a drug therapy? And he asked this question in the pharmaceutical paradigm. And of course, LSD and other substances. I often speak about LSD because I'm most familiar with this substance, but it applies to other substances as well. Yes, it is a drug in the pharmaceutical sense because it's a specific substance. It is described and defined and influences a pathophysiological process. It has a clear profile. Historically seen, LSD was a licensed product already. It was branded under the name Delicid. Actually, it's a scheduled substance. And all the research that is done actually with these substances, of course, is in the pharmaceutical paradigm. These substances are treated like any other kind of drugs. That means, for example, that we have to do our research with a controlled randomized trial that causes a specific placebo problem. You may know about this, that it is difficult to have a blinded trial because all the time LSD will unblind the conditions. This is discussed a lot. I think we cannot solve the problem within the pharmaceutical paradigm because you cannot compare LSD with placebo without having known for the patient and the therapist what it is. However, there is no other way, no alternative. We have to go in that way for making LSD, psilocybin, MDMA, and maybe other drugs registered substances and medications that can be used in the normal clinical way. But it is not only and maybe not mainly a drug therapy. In my opinion, as a psychotherapist, it's a kind of therapy. It's a kind of psychotherapy. And there we are in another paradigm, in the psychotherapeutic paradigm, where we have LSD and the other substances more or less as catalysts or enhancers of psychological processes. The people, they experience processes of deep psychological or meaningful layers, which Stanislav Grof caused LSD or defined LSD as a microscope or a telescope of the psyche. LSD allows to go on regressive and biographic states in a daydream-like manner, and people bring that back then from that experience, and we will help patients integrate these experiences afterwards in a psychotherapeutic process. LSD is in a way non-specific, that you will not have a specific process. You will not have a clear, even when patients have a clear intention. Tomorrow I would like to know something about my Parkinson's disease. I have had a patient like that. He really wanted. The next day, he had a blissful state of deep unity and insights in creation and deep connection with himself. And it was not 1 second about his Parkinson's disease. So this is not predictable what you will experience when you will take LSD. It's more like a door opener. It opens the doors of perception, like Aldous Huxley described it. And when the doors are open, then it can be anything. Anything can happen. You never know before, and that is also one of the reasons why we think that you should be guided in such an experience, because it is non-predictable, not in the dangerous sense that it is very dangerous, but it is you never know. It's always new. And the third treatment principle is the spirituality. We have, although I define myself not as a spiritual teacher or a meditation teacher or somebody like this, I'm a psychotherapist. Nevertheless, there are patients experiencing very often, quite often, spontaneously, so-called spiritual experiences of sacredness, of unity, of connectedness, with themselves, with creation, with nature, whatever mystical experiences. And I think although we do not teach that, we should have an open mind for this, and we should understand and help patients to integrate when they have such experiences. There, I think Bill Richards has written a book about, the title is Sacred Knowledge, and I think he is quite sure that this is the most important factor of a psilocybin session, or also with LSD, but he worked mainly with psilocybin. That is the most important factors that people have spiritual experiences. This is one of the healing principles, in his opinion. I'm more on the psychotherapeutic level. I think even when people do not have spiritual experiences, they can have a very helpful therapeutic process. And the treatment principle number 4, that's widely known already. When in the 1940s and 1950s, when the research started with patients, the therapists and the researchers learned that the substance not alone is responsible for the outcome and for the effect of the drug. So that there are other factors that are as well important to give a prediction of how it could come out. And then Leary and others described this triad of the substance, the set, and the setting. Setting means the surrounding, the circumstances around the person and the substance. So like also the therapist and the room you are in, the music you are listening to, all that is summarized under setting and the set. These are the inner factors, the belief systems, the intentions, the fears of the patients, also his diagnosis, of course, so that are the inner factors of the patient. The substance, also the dosage and the kind of substance that you are taking is just shown in this triad. Let me say one or two things about the setting in Switzerland, what I am practicing, what we are practicing. On one hand, in our research projects, we are treating in the individual setting. There's just one patient, one therapist. This is on this picture, you see my room in my office, in which I normally work. I put the chairs aside and the mattress on the floor. I think it's more convenient and more appropriate to work on the floor. That was my experience on the sofa. It's not the same. You can hear approach from every side, and the patient is already just grounded in the sense lying on the floor. I'm playing music here. It's a quiet and undisturbed environment. And I'm personally present during the whole time of the action of the drug. I'm with the patient. I'm pay attention to what's going on. Even when there is apparently nothing going on, I'm aware of the process and what could happen inside the patient. On the other hand, since we do this compassionate use program, we started to treat in groups. We have, together with a friend of mine who has also the possibility of get approved compassionate use treatments, we started a group. And the advantage of a group that it means there is a possibility for interpersonal contact, especially in the last part of the experience. People appreciate to be together with others. Maybe they have small talks, maybe they spend a little time during a break together. And also the next day when we have these integrative talks, you see that the group is working and people make experiences that it can be helpful to listen to others, maybe dealing with the same problems, maybe giving advice to them and their process. So we prefer doing most of the treatments in the group. Of course, there is also an economic point of that. It will be when we do this treatment one day, normally and legally, it will be very, very expensive to treat one patient during 10 hours with LSD, for instance. That makes it very expensive. Could be easier to do it in groups and people giving the possibility also to have an individual process in that. The next slide is next treatment principle, another triad I formulated here. On one hand, in the dark blue circle that's the guided experience, but the guided experience is followed. No, it's not followed. Before the guided experience is a preparation phase. So preparation phase means mainly when they start with the patient to build up a relationship that is based on mutual trust. You have to answer questions. People ask about the setting, they ask about the substance, they ask about what will happen to them. And I think this is building up the whole set for the patient so that they can say at the end, now I feel okay. I can imagine I can go on and do the guided experience. Then the guided experience, which I was showing before, which is guided by the therapist all the time. The experience lasts. And then the time after is a helping phase within the therapy, the integration, to put that in a meaningful way together, to ask the question, what was this all about? How does that help in my everyday life? And then this is the last of these treatment principle slides. We in Switzerland, and maybe Thorsten Passi will talk a little bit more about that. We'll show you the difference of psycholytic and psychedelic therapy. I will not go into details, but it means we think that these experiences are part of a conventional psychotherapy, and it has to be followed by a process of psychotherapeutic talks before, in between, and after all these guided experiences. And this is mainly the psycholytic approach. The psychedelic approach was mostly doing 1 or 2 high dose sessions, and the high dosage makes you having a spiritual experience, which in itself is helpful. And now that the research projects nowadays, they are mostly 1 or 2 dosing sessions, which in some way means this is more the psychedelic approach, and we really rely on having one or 2 experiences will heal from the condition. But maybe we have to become more aware that some conditions, I think it will be also depression, needs maybe more than 1 or 2 sessions. And then you do 5, 6, 7 sessions, and that will be the psychotherapeutic process. In Switzerland, we had a phase for 5 years from 1988 to 1993, where we had done long-term treatments. I was too young at that time, I had no approval for doing these therapies, but 5 therapists did, and they treated 171 patients in 5 years. And I sent them a questionnaire, 121 answered. And that has shown that the duration of treatment in Switzerland in this treatment phase was around 3 years in average. During these 3 years, these patients had 70 talking psychotherapy sessions. And in these 3 years, they had about 7 drug sessions, MDMA or LSD, or MDMA and LSD, but not one after the other, always. So under naturalistic conditions, we can assume that the treatment is a treatment of more than 1 year, and you will have more than 1 or 2 sessions. The sessions were in average between 3 and 5 minutes in a row, and all the time 3, 4, 5 minutes in between. I've 2 slides for the future, what will happen in the future, in my opinion. The global view, I think at the moment there is a growing interest for this kind of therapy. That means also that the university and the pharmaceutical industry will show their interest, and they will help, or they will take over. That's the way you see it. It's a kind of perspective, but I think that will make this, that we will have more describable and evidence-based processes founded on scientific concepts in the end, with trainings based on these scientific concepts. Maybe they will lead also, hopefully they will lead also to medications. There are no more scheduled drugs, and we can use them for therapy regularly. And also that health insurance will cover the treatments because they will have shown efficacy. There will be a growing need for a sufficient number of therapists, be it for the studies that will take place the next years, be it then for therapy as well. Also, but there are 2 questions in my opinion. One is personal growth. Will it be possible for healthy people to get access to these substances for doing personal growth or personal growth experiences? And the other question is, what about backlashes? What happens when there will be difficulties and severe incidents? Will it be a backlash like it was in the 1970s, or will we proceed on? And then the future in Switzerland. We hope to develop our program for compassionate use, individual treatment approvals. We will have also in Switzerland further studies, phase 2 and 3. Katrin Preller mentioned the psilocybin studies in Zurich. In Basel is the same. There is a group around Matthias Liechti and Felix Müller doing LSD with depressed patients. We will do therapist trainings in Switzerland. We do one at the moment. We will do more, I think, with the deep wish and will to allow self-experience with these substances also for these trainees, because we are profoundly convinced that you need to have an experiences with the substances to guide other people, just to know what can happen to them. And that this is, I mean, that's the core issue with all psychotherapeutic training, to learn the method by experiencing the method itself. It's the same with psychoanalysis and other psychotherapeutic methods. We have a discussion of ethics at the moment. We think that's very important. There's a special ethic concerning this topic. And also the public information that has to influence the public opinion. And I think now for the last 10 years, I think we came out this very defensive atmosphere of prejudice. So we had to always to tell that our method is good and valuable and effective and all that. But I think the more public interest is now big, we also should change a little bit to talking about difficulties and dangers of the methods, not because we do not want to give the imagination that this is a therapy method that could help everyone, and this is a magic therapy, something like that. Okay. The take-home messages, my last slide. This is more or like applicable to LSD and other drugs. I have made it here for LSD. The second point, LSD in doses above threshold is not a drug in the common pharmaceutical sense. It can be understood as an enhancer of physiological, psychological processes. However, it is treated as a drug like others in the regulation process. And LSD has to be incorporated in the psychological treatment due to its broad variety of action and unfolding of non-ordinary states of consciousness. Thus, the need for sufficient safety of application and for psychological guidance and safe contact afterwards of integration of the acute experience. And 4, the current research and re-evaluation of LSD gives promising signals towards a reuse in several medical indications. Thank you for attention, and I'm curious of your questions.
Thank you very much, Peter, for a very interesting lecture that I'm sure also offers points of discussion for the Q&A after the next session. It is an honor to introduce Torsten Passi. He is an established researcher in especially psycholytic therapy, which he will tell you about. He studied philosophy, sociology, and medicine, and he led the Laboratory for Consciousness and Neurocognition at Hanover Medical School, and his clinical research is basically on altered states of consciousness, including studies with breathwork, cannabis, MDMA, laughing gas, ketamine, and psilocybin. So he has a very broad knowledge on the different effects also of the different substances. And he had the prestigious position of visiting professor at the psychiatry department at Harvard Medical School to also teach on this. Professor Passi, the floor is yours.
Yeah, you just have to help me how to introduce my lecture on the screen, because I'm not really accustomed to do that.
All right, so at the bottom of your screen, you see, on the bottom of the Zoom call, you see share screen.
Yeah.
So if you click on the share screen, you can share your PowerPoint. And it should be one of the options there.
Not really. So I can't find it here.
So if you have you don't see the share screen, or you don't see the PowerPoint there?
No, I don't see the PowerPoint there.
Did you open the PowerPoint on your computer? Yes, most probably.
Let's see. Now I have it on my computer.
Yeah. And then
Let's
share
see.
screen.
Okay. Oh yeah, now it works.
Perfect.
I hope so.
Yeah, so you can start the presentation.
Is it really on your screen then right now, or?
Yes, we can see it.
Okay, okay. But I'm on the wrong page, so to say. Let's see, just here. Sorry for that delay.
Never mind, it's very clear now.
Now we are there, right?
Yes,
Yes,
we are there.
perfect.
Okay, so thanks for the nice introduction. I had the idea, or I came to the conclusion from all the research during the last 10 years that we had obviously research on MDMA-assisted psychotherapy as well as on psychedelic therapy, which is a specific paradigm, for example, in contrast to psycholytic therapy. But interestingly enough, the classic approach, the psycholytic therapy approach, wasn't represented anywhere. Nobody studied low-dose LSD. Nobody did imaging on it. Nobody did research on low-dose psycholytic therapy, which is in fact the classical approach. There are some reasons for that. And so I thought, okay, why not doing a lecture about the neglected approach, to my eyes, the conventional low-dose psycholytic therapy. As I had to shorten my lecture a bit, some aspects can't be covered here, obviously not in 20 minutes, but I hope I can give you a rough idea about the approach as well as on a few working mechanisms which might be specific for this approach. Okay, just a short overview. I give you a short idea about the history, then about the paradigm of psycholytic therapy and some ideas about the mechanism of action, and then a short synopsis. Okay, what is the history? The history obviously is shamanism in the far past. And in the first psychoanalyst or psychotherapist who has used hallucinogenic substances was the Italian psychoanalyst Baroni in 1931, where he used mescaline mixed with other stuff, for example, alcohol, as a potion to further psychotherapeutic processing in psychoanalytic cures. And then in the 1940s, even before LSD was discovered, there were approaches to use kind of daydream-like states of enhanced imagery for psychotherapeutic purposes. So that was a kind of context somewhat. And then Stoll, who is shown here, very rare picture, by the way, you can't find any on the internet. Arthur Stoll was the kind of relative of the laboratory chief where Hofmann discovered the LSD molecule or LSD action of LSD. And so in 1945, he conducted the first study at the Psychiatric University Clinic in Zurich with using LSD in very low doses of 10 to 30 micrograms. Everybody was being afraid because of Hofmann's psychotomimetic reaction on the bicycle ride. So they just used a tenth of that dose, usually in this time. So Stoll's study made obvious that a low dose LSD might help to memorize traumatic experiences and also induces a kind of daydream-like state. This is why these people using daydreams at the time, for example, Frieda, King, and Leuner, were immediately going to LSD to further their approach or their technique. So Leuner, Hans-Karl Leuner, is shown here in a younger age, Sanderson in the UK, and Grof in Czechoslovakia were the major exponents of that approach. So in fact, we just had a very few, I could say one person who has used the psychedelic approach in Europe during the 1960s, but we had 18 academic European treatment centers where the psycholytic approach was performed. So you could say Europe is psycholytic approach, the US were much more into the psychedelic approach. Just a very few centers in the US have also used the psycholytic approach. So here my statistics about the publications which have been issued during a certain time span, and you can see that in the 1970s it's going very low, but you have to realize that you could say more than 2/3, I would say 3/4 were about psycholytic therapy and just 1/4 about psychedelic therapy, just to give you an idea how dominant kind of that other approach was in that time. And more recently, we had that interruption of research. Everybody knows that during these 30 years, and furthered by MAPS and some American as well as Swiss millionaires, where some studies coming up since the year 2000, more and more, but they were kind of privately or non-profit, in a non-profit way financed. And in the late 1990s, when some of these guys were sitting together, they were thinking, okay, we just have a very limited amount of money. How can we prove with the most effective approach? It's not approach about efficacy, it's a most effective approach to prove the positive effect of psychedelics on mental health conditions. And we came to the conclusion that short-term studies might be easier to conduct as well as cheaper. So it means we focused on the psychedelic approach, where you can, with 1 or 2 doses, you can effect some personality change in a very straightforward and massive sense. And so it's easy to measure. There are not so much interferences with other aspects of the patient's life, which might be much more interferences if you have a span of 1 or 2 years of psycholytic therapy, which is much more slow, so to say, and much less drastic in a 1 or 2 dose approach kind of way. And so it was a kind of paradigm. So the psychedelic paradigm was preferred because of being a more effective way to bring up the first proof that even under methodological sound conditions, these substances can have a positive impact on mental health conditions. But at the same point, the neglect on psycholytic therapy showed up. So nobody was studying psycholytic therapy anymore because everybody was focused on psychedelic therapy out of these specific historical circumstances. And there is, up to now, no imaging research on low doses, virtually none, and no research on psycholytic therapy and how efficacious that is and how that can be optimized and so on. So it is in fact a neglect in science right now, to my eyes. So then psycholytic therapy itself, it was called psycholysis, and you can see it was developed in a kind of psychoanalytic framework, which was very dominant in psychotherapy at the time. And so psycholysis is somewhat coming from psychoanalysis. And the language correction programs today always change psycholysis into psychoanalysis. The term itself was coined by Sanderson in 1960s. There's no better pictures which can be reached about him. And at the first international symposium held by Leuner in Göttingen in 1960. And that term was unanimously accepted by the community at that time. And it means that you usually apply or administer 50 to 100 micrograms of LSD during 5 to 20 sessions, usually. And the duration was minimized or limited to 4 to 5 hours. And the action of LSD was stopped usually by a tranquilizer, a neuroleptic, or a benzodiazepine, so that the patient could go home or the therapy would end it, and not too stressful for the patients as well as for the therapists. Later on, psilocybin came up with a shorter duration of action. Inpatients were preferred to be treated, but outpatients have been treated very much with that approach too. The last development of the psycholytic approach in a clinical environment was the so-called stationary interval treatment, which has some similarity what Peter has introduced us to, which means that the patients will go to the clinic a day before, stay in the clinic for the LSD treatment, and will be left out the day afterwards. So a 3-day clinical setting, and that may be repeated a few times. This is called stationary interval treatment. It might represent the future still if we go forward with this approach. So the setting is, as well as what Peter has told us, embedded in a long-term psychotherapy. So it's a catalyst of that process, which is going on anyway. And there was a paradigm that the patient was never left alone, because some complications were showing up when the people were left alone. Nevertheless, some therapists were kind of insisting that LSD in the patient's soul or brain might do the work by itself somewhat. And in some cases, people or patients were treated successfully by leaving them alone. They just had a kind of button which they can push so that somebody might come up and help them. But this might present a problem if a person has a certain psychological problem and has a transference problem. So I never ask the father because he always beated me, so he will never push the button and might go into a fearful and anxiety state, might even go into a horror trip, and the therapist might find him later and so on. So it was preferred to not leave the patient alone. And they also used a technique which means that the therapist, the highly qualified therapist, will not be always with the patient for all the time. A nurse or another kind of assistant might sit with the patient, and the therapist might show up once in a while during the process. This was at last the classic model. And there we recorded, I've worked myself with that approach for a few years with Hans-Karl Leuner. So I know that we tape recorded all the sessions and asked the patients to do a written protocol about the sessions. Usually the patients were hearing their own voices on the tape recording, and then they do a kind of protocol about it. And when the patient show up for the next session, we will do psychotherapeutic handling of to integrate the things which have been experienced the last time, but there will be also a kind of integration session directly after the action of the drug has been stopped. If the patient is treated in a clinic, usually art therapy was found very useful for integrating the experiences and to bring up in the psychotherapeutic communications pictures or even sculptures and so on. I just want to remind you that the very prominent book of Stanislav Grof, Realms of the Human Unconsciousness, who has read that will find in there that this was mainly, or I could say 80% of that book was based on psycholytic work with 50 patients in Prague. So the main building block of that book was psycholytic therapy. I just want to remind you on that. Here you will see a picture with Hans-Karl Leuner beside I am on the left side, and he's sitting with the patient when he once in a while came in and handled the patient in a way that the patient might relax again and feel well if he's not, and then he will go out again and leave the patient alone. So a general thing is that the therapist or the sitter, which I was here on the left side, did not talk to the patient. He's just receptive, so to say. We will interact with the patient a little bit, but we are not supposed to speak to the patient and ask him, or what's the matter with your mother, or stuff like that. Not like that. It's more like accompanying the patients, not guiding him, right? We are much more passive. Okay, what was the settings? Usually outpatients in office, as we had when I was working with Leuner. We also had inpatients, and we had 3 to 5 inpatients treated simultaneously. So I will show a sketch of that later on. We had a specific office where we had 3 rooms at that point in time when I worked with him, with different patients, and every patient had a separate room for himself. It was kind of individual therapy, but afterwards, when the patients have gone through the session, then we were coming together and discussed it, the experiences in a group setting. And on these wards, what Leuner and others have led at that point of time, a kind of therapeutic community, which is a specific paradigm of interpersonal milieu, has been used appropriately. Here you can see a rough sketch of such a treatment unit where you have a few rooms and a group room where the people might come together afterwards. And here you can see, in fact, the building block of the LSD unit at Powwick Hospital in the UK, which was exactly, as you can see here, designed that way. It was partially financed by Sandoz, by the way, to establish that approach. And I just want to give you a short idea what kind of substances have been used. Especially noteworthy are the three ones here: CZ74, CE epsilon 19, and 2CD, which are 2R psilocybin derivatives, which are much more short-acting. So it's more 90 minutes to 3 hours in that range. And 2CD, it's kind of the same. That was the last substance Leuner has done research on, and we have treated our patients with 2CD. Also, entactogens can be used with that approach. Jensen's approach in the Johns Hopkins group in the 1970s or early 1970s was also psycholytic using MDA, and later on MDMA and MDE has been used in such settings too. Okay, about the treatment results, you know that there were kind of methodological problems at that point of time, but these statistics, which have been compiled by Mascher about the treatment results of the therapists, which were quite a bit. We had kind of 50 or maybe even 70 psycholytic therapists at work at that time with the psycholytic approach in Europe. And so here you get a rough idea which kind of a diagnosis can be treated well with that approach. You see that anxiety neurosis, depressive neurosis, and character neurosis were the main indications. We call it character neurosis, we call it today personality disorders. Okay, I just want to give you 2 quotes about that approach. You can read yourself. I've especially chosen quotes from people which have not explicitly used that approach, but have a broad spectrum of experiences using psychedelic drugs, even in the low dose range. So you can see that it is also with experts saying, okay, that might be a good idea to use these kind of low doses with patients. In respect to the mechanisms of action, I can just give you a rough outline of a very few factors, but might be illustrative for it. The general idea is that the low-dose hallucinogenic drugs induce a hypnagogic syndrome, which is comparable to the pre-sleep state. Before you go to sleep, sometimes you go into a kind of otherworldly kind of state, which has some similarity with the low-dose psycholytic state. They called it at that point of time a functional regression of the psychological functions and the cognitive functions, so means to a more primitive mode, also characterized by passivity. At the same time, the inner stimuli production is increased so that you got more visions, more thoughts, and these kinds of things, more feelings. There's also a kind of narrowing of consciousness in that sense that you're much more concentrating on your inner world, so to say. The inner stream of consciousness, so to say. The associations were loosened and a dreamlike state was induced. Decrease of outward perception if you are in a psycholytic setting with eye shades and mild or by music. And the ego is not as much altered. That's a central point, because right now the paradigm is that we dynamite the ego away and then we might reset the brain somewhat. That is quite different with the slight ego alteration in the psycholytic approach. But nevertheless, you have an activation of your affectivity or your emotions, and a lot of conflicts, inner conflicts will show up. Leuner has one time termed that the psychedelic is a promoter of the psychodynamic of the patient. And psilocybin in Vollenweider's early studies has been shown to alter in the center of the brain. You can roughly say that there's the thalamus, which is a kind of relay station for presenting the stimuli from the inner realm into the brain. And this kind of reduction valve is much more opened when psycholytic doses are given. So you experience more of yourself, more of your conflicts, more of your imagery, more of your thoughts. A very important theoretical or clinical result from Leuner's very thorough research with more than 1,000 sessions under the same controlled conditions with LSD was there were two courses how the flow of experience will go on. In the so-called continuous scenic course or quasi-normal course, there will be a smooth, continuous flow of images and insights with much less ego alteration than with the psychedelic approach. And that was very important to him. There is a holistic sense-making integration with the appropriate effects of the patients. There is another course which he named stagnated fragmented course, which is characterized by a kind of overexcitement and the fragmentation of the inner experience. It is more a disintegrated, erratic flow of experience. If you want to dynamite the ego away, that might not really carry you. And I will give you a diagram to make it more obvious what is meant by that. This here, for example, is following Leuner's diagrams, the flow of the experience during a few hours with the continuous scenic course. And important to know is that within his theory, there is a certain amount of arousal which determines the course of the action. And this line here, the additional line, this one, is there to show you that the psycholytic doses are not bringing the people in an egoless state. It's just a little alteration of the ego, and it's quasi-normal, the performance in the brain and in the inner flow of experience. So it's well integrated. It does make sense what follows one another and so on. And if it comes to the stagnated fragmentary course, which is more justified to be named psychotomimetic, you come over that toxic threshold here, so to say, and your experience might be fragmented and irritating and so on, and the ego might disintegrate. So Leuner concluded that it's much better to not disintegrate the ego, but leave it mainly intact so that you are below that threshold where the fragmentation might go on. But nevertheless, during a course of action in the continuous scenic course, you might go over the threshold if some arousal about specific contents might show up. So it's not obvious that you never reach that threshold, yeah? But it's kind of harmless because it's just temporarily that you go in that over the psychotomimetic threshold. I can't go too much into these things, but what was interesting is that Leuner as well as Grove had the same conceptualization about the course of the the unfolding of the experiences in the course of psycholytic therapy. It was a miracle to them how are the contents of the experiences determined. And Leuner, at first in the early 1960s, hypothesized about transphenomenal guiding systems which guide the experience and what follows after each other. And Grove came up with kind of the same context in a way independently called systems of condensed experience. And it was originated from that question, how do experiences unfold in the course of psycholytic sessions? And it was discovered independently, but the concepts are mainly similar. I have to explain that a little bit. So these transphenomenal dynamic systems are dynamic systems constellating memories and experiences during the course of psycholytic therapy. Symbol-like visual projections of emotional states are most characteristic for these constellations of memories and how they show up. The core emotions or deepest roots of these can be said to be equivalent to affective complexes a la Freud or Jung. It's the same with the coexistence of Stan Grof. And they can express themselves, these kind of dynamic systems, in a verbal way, in a symbolic way, and in an emotional way. It depends on the content and the phase. And these memories are viewed as kind of tension systems, which can be activated by LSD. If the tension is very high, it can easily be activated and then can go into these expressions, per verbal, symbolic, or emotional expressions, and then they can be kind of abreacted and lose their energy. Their energies are consumed by abreaction, coming up and being lived through in a way with appropriate effectivity. And to give you a more concrete idea, I will use a very old paradigm which can illustrate that very good. So if you let a person, an experimental subject, associate in a usual state of consciousness, and you do that with 100 persons, then you will find that there is a usual pattern of association. For example, if I would give you the word as an initial word, love, a lot of people would have the same association: heart, being near somebody, my wife, and so on and so on. So you have a usual frame of associations, so to say. If you have a person which has a specific problem in relation to sex, for example, then you might find that these associations are kind of incomplete. The pattern is incomplete because there is a complex there, a psychological complex with certain tensions and avoiding patterns. And so you can't find the complete thing, right? So what is happened during psycholytic therapy, that is one aspect, is that these affective complexes and these avoidance patterns, these places where the associations are not there, will be completed because the coex release will lead to more and more parts of being kind of reconstructed and lose their tension. So the avoidance pattern is going away, so to say, because you realize you integrate these parts much more than before. And you can see that here symbolized by these dots.
Thank you, Torsten. So we should be moving to the Q&A shortly. So could you maybe take one last minute?
Yeah, sure.
Thank you.
So the mechanisms of action are, in a very short format, affective complexes turn into visions and emotional states, or transference action. Memorization and affective abreactions are important factors. The strengthening of the transference, the visibility of defense mechanisms, which can be seen easily and realized by the patients. Productive alterations of scenes, so also there can be fantasies which alter the usual contents of the experience, like the pattern how you behave about your mother might be changed in your fantasies, coming up in psycholytic therapy. And there are also spontaneous insights and analysis of the patients, analyzing their own experiential content. So here's my synopsis. So I'm kind of in time, I hope. There is a neglect of psycholytic therapy right now, quite a bit. There are different mechanisms of action with psycholytic therapy, might be much more subtle and much more broader in its spectrum. There is also the question of durability. So it might be true that psychedelic therapy might have a certain impact for a while, but we know from the studies in the 60s that you go back to your pathological state after a while if you are not continuously supported. These results were uniformly in that respect. And this is what Peter was talking about. There is another approach which combines somewhat the psychedelic and the psycholytic approach, which might be the approach of the future, already called or named psychedelic therapy, where you have a few high dose sessions, but the main thing is done with low dose session or somewhere intermediate in between of them. Thanks for your attention.
Thank you, Torsten, for a very interesting lecture. I loved all the three of your talks, and I think you have together provided a very thorough, even though it's a brief overview of both the history and also the applications of these treatments. I'm very happy that Katrien is also present in the session now. We have seen your lecture, which went perfectly well. There are now 19 questions, so the audience is quite active, actively consuming what you have told them and processing it, which is one of the topics of this session. And they present you with the preliminary results of those processes. So, I was looking through it. Maybe Katrien, because we haven't seen you in real life. And also I have to mention that Mendel Kalen is here. He is one of the pioneers of the music and the whole environment assist of psychedelic therapy. He developed that in Imperial College in London and now takes that even further. So we're glad you're here. Please feel free to also comment if this is within your expertise or interest. But before that, Katrien, there was one question that may be a bit hard to answer. The question is that the decrease in connectivity is also seen in Parkinson's disease and other in Lewy body dementia. In these diseases, we see patients who experience vivid hallucinations called Charles Bonnet hallucinations. Did you see the question?
I did. So can you hear me well?
Yes, very
Perfect.
well.
Well, first of all, I'm super happy to be here. I'm so sorry I couldn't give the talk in real time, but I'm glad to hear that it worked anyway.
It worked perfectly, no problem.
So yeah, regarding this question, it is kind of hard to answer for multiple reasons. But what I found really interesting is that indeed there seem to be some kind of overlapping patterns of alterations in connectivity. And that is definitely something that is interesting and that should be explored further. The kind of caveat on the studies that have been published with these patients so far is that none of them used exactly the same method that we have used to investigate the effects of psychedelics. So to be able to really answer the question if there is the same pattern underlying the visual alterations or hallucinations induced in these patients as well as with psychedelics, we kind of need to combine the data sets and analyze them together to see if we indeed find the same pattern or where the differences are. And that being said, so if someone has access to a data set that is collecting resting state in these types of patients, we're always happy to collaborate, send them over, we'll analyze them compared to our psilocybin data or LSD data. And after that analysis, I'll hopefully be able to answer this question much more concretely.
Thank you very much. I can imagine very well, and who knows what may come out of it. There's another question on your talk that regarding to a predictive measure. I'm not sure whether that was referring to the ketanserine, which is maybe not really a predictive measure, but what would your reaction be to that? Are there predictive measures? Do we know beforehand who will have a beneficial reaction? And would this be an imaging marker or some other kind of marker?
Yeah. So this is a very, very good and super important question. And right now, I think we still don't have necessarily the answer for that. We've seen some kind of predictive markers in terms of behavioral or trait personality measures, as well as like set and setting measures that I think about 10 years ago, Eric Studerus has analyzed in one of his publications, where we know that there are certain factors that the people bring to the experience as well as the surroundings can influence the acute experience. Obviously, all of these are, so those are definitely super important. But of course, we kind of would like to also know this on a more fine-grained level, and that's why we looked at brain connectivity measures and tried to predict how people or how strongly their brains would react to the substance itself. And from this analysis, we've seen that there is indeed a pretty high, surprisingly high correlation between how the brain, to kind of put it very simply, of course, how the brain is wired in your baseline state to how it reacts to a psychedelic. But that being said, we always need to know that finding these predictions or these correlations is always very hard in the low sample sizes we have. That is why I think the paper published on personality and things like that is at the current stage much more informative, because here we were able to leverage a data set of like, I think 300 participants, whereas the analysis I presented in my talk is really based on, I think, 23 people. So that always, you know, so when you're looking at that, you always have to keep in mind it's a very low sample size and we need much more data to eventually be able to say if we really can predict the experience or the changes induced by a psychedelic from the baseline state. But it is a first hint that this might actually be possible. And if that turns out to be true in larger sample sizes, I think that would indeed be very valuable to stratify patients before we administer the substance, and at least have some kind of hint who might react in what way to these substances.
Thank you very much. Very clear. I have a number of questions for Peter. Some I think you might talk about for another hour, so that's a challenge. And some are more factual. So let me try to feed you some factual questions and then one broader question, and then we'll move to Torsten.
Okay.
The most factual, is there a maximum to the size of the group in your experience?
Yes, well, we wanted to have no more than 12 people. So 12 is our maximum size of the group. And with 12, we had the experience it works. So with 12, we have been the 3 therapists, 2 male and 1 female therapist supporting the 12.
Okay, thank you. And there was one question that 7 people voted for, is whether you have seen backlashes. You talk, well, for example, persistent hallucinations, those kind of backlashes.
No, we didn't see HPPD. Even we did not see a severe crisis that we would have people to go to hospital after that. I think still we have a very careful selection of patients. So we exclude people suffering from psychosis in their lifetime or having psychosis in in the family. And we exclude also people with severe personality disorders like borderline personality disorder. So in this setting, we didn't have severe backlashes. I think we do have people who have not so a good progress in the therapy, and there I'm more reflecting what are the reasons what people do not have a benefit or a clear or a strong or a long-lasting benefit. I think there are limitations to the method which we do not understand thoroughly at the moment, but backlashes, no.
Okay, thank you.
I can confirm that.
Yes, please.
I can confirm that from the group work which I have participated in for 15 years. We never had these kind of problems. We have not seen HPPD. We have not seen flashbacks in a bad sense or something like that. Some people use these flashbacks like hearing the same music and going into the same kind of state and stuff like that. But otherwise, we haven't seen these complications, and we didn't have that much of a narrow spectrum of patients. So it was kind of broader, and we didn't control so much for personality profiles and stuff like that. So, and we didn't see these complications, but we also had a therapist available for 1 or 2 weeks afterwards on a steady basis, even at midnight. So to say, this was not very much used, but I just want to make aware that. And the main kind of, I wouldn't say drawback, the main thing, kind of complications, what we have seen is that some people might go into a kind of labile psychological state on Mondays. If they had the session on Saturdays, the integration work on Sunday, they might come into that. But this is, I would say, 1 out of 50 or so might go into a labile state. They usually can handle that themselves even, and otherwise they could call us up. And so we never confronted real problems, and they were always, how should I say, put it together on the same day, and there was no long-term effects that way.
Okay, thank you. And it reminds me, we have now treated around 12 people in the psilocybin trial, and we have a sort of first impression. And these people are selected because they have a depressive disorder and they haven't reacted to at least 2 antidepressants, and that's it. And we have the impression that patients who have less introspective capabilities, less possibilities of verbalizing, which of course is what you would expect, but they may be more overwhelmed by this experience and may have more trouble integrating and putting it to a constructive use. Do you recognize that?
So from my experience, I have mainly worked with the psycholytic approach as well in these group experiences where MDMA and MDE were dominant. And so these substances and low dose administrations do not disintegrate so much. Mm-hmm. They leave the ego more intact. And so that might be different with the psychedelic approach. But I would say that the people which came into a labile condition afterwards, it was more like this, I shouldn't say that, an alteration of their personal constructs. For example, I'm a person that or that and that way, they would think of themselves. That might be changed during the session and afterwards. And so that thing collapses, so to say, somewhat. Their narcissistic constructs somewhat collapses, and that might bring up these lability. But this is in fact a progressive state. It's furthering therapeutic work if handled correctly.
Okay. Thank you very much. Torsten, maybe one additional question. Why do you think addiction treatment needs higher dosing?
So this is not what I think, but...
no, well, sorry, the question was what do you think, but sorry.
Sure. I think that they had very successful treatments with alcoholism in the 1950s and 60s. And this was in a way consistent, even by the meta-analytic stuff that was done later on about it. And I think that there was a consistent clinical observation, which we had too, with a few patients we have treated with a psychedelic approach, that alcoholics especially are kind of much more mystics, I could say, than other people. So there might be a specific personality pattern. I'm an addiction researcher myself, so I know there is no definite personality pattern about it, but there might be, I've hypothesized for myself, there might be a better permeability to ego dissolution and these transformational potentials of an ego dissoluted or an ego transcendent state. And some people have, for example, William James has said the cure for dipsomania, drinking, is religiomania. And so these kind of things, this is, I think, another idea what Katrin could do research on, what kind of personality, specific personality constellation is in these alcoholic patients predisposing them for having mystical experiences and profiting very much from the aftermath of that experience.
Katrin.
So, yeah, I mean, as you probably know, Torsten, we're currently conducting a study with psilocybin and alcohol use disorder. And within that study, we're not only looking at clinical outcome, but we're also looking at mechanisms that might be predictive of therapy success, or that might underlie whatever is happening. And we're certainly also looking at personality and things that, again, might be predictive for the therapeutic outcome as well as the acute experience. And yeah, that study is currently running, so I can't really tell you any results about that yet. But maybe if we have this conversation again in 2 years, then I might be able to answer at least some of the questions you asked.
Yeah. I like it very much that you are looking for these long range things, because in the 1960s, it has definitely been shown by the methodological better studies that the patients go back to their alcoholism pattern after a while, if not supported appropriately. And I think we can produce illusions about therapeutic efficacy if we, as the behavioral therapists tend to do, just look out for 3 months and 6 months and stuff like that, you know, and so that might produce illusions in a way instead of real results.
I completely agree. So it would be nice to follow them up basically for the rest of their lives. And I think it would actually be worthwhile doing that. Unfortunately, obviously, that is a matter of money, right? So it's time consuming and it costs a lot of money, and also willingness from the patients, of course, to answer questionnaires and or maybe even come back to the hospital. Yeah. So again, you know, it's a matter of money. So I'd really love to do that. So we're trying to follow them up as long as possible. But of course, we might miss relapses. That is almost certain. But in my head, you know, if it helps them to abstain from drinking, or at least drink less for a certain amount of time, and even if it's just 3 months or just 6 months, I think that can already be very, very helpful. But again, you know, I agree. Longer studies are definitely needed. It would be great to follow them up. If someone is willing to fund these types of studies anytime.
Yeah, it might be financed by the government because it's more kind of basic research. And one could also say, okay, let's take these 100 patients and try to select a representative sample of 15 and follow them up for a longer time. Another approach could be, I think you would be okay with that too, is to use different kind of therapeutic measures during the time afterwards. Maybe reached from maybe a spectrum from no therapy up to, like with compost or so, up to continuous psychotherapy afterwards for 2 years or for half a year or stuff like that, and vary these kind of approaches. And then you could see what is the ideal measure to do.
Torsten, I couldn't agree more, and I think you're actually touching on a broader topic within the whole framework of psychedelic assisted therapy. That is that we actually don't have any empirical data on how the therapy should be. So the therapy that comes with the acute dosing should be conducted, right? So we're kind of, a lot of studies are relying on, you know, the approach that, you know, you're there mostly by your own. You have, you know, a couple of people that are sitters or therapists, etc. During the acute session, and you're kind of relying, or most people are relying on some kind of like mixture between a psychoanalytic, less so cognitive behavioral therapeutic approach. But to be honest, I mean, we've never really tested that empirically, right?
Yeah.
So all studies just, you know, kind of dependent on, you know, like more or less anecdotal input from what happened in the 50s and 60s. We kind of try to come up with our own therapeutic model within our studies. Whether that is the right way to do it is an open question, because we don't have any empirical data that say like, well, if you do this intervention and then do this, do the dosing, during the dosing, you might do this intervention and afterwards you do that. We just don't have any data on that. And I think that is one of the major blank spots within the new wave of psychedelic assisted therapy. I
completely agree.
Me too. This is a very enticing research topic also. Maybe Mendel, there was one question for you that relates a bit. So Peter was talking about the substance setting frame and explaining how difficult it also is in studying the effects of these substances or these therapies, because they are so intermingled, and placebo, there are no very good placebos. One of the contextual factors is what Mendel is specializing in. And as Katrine was saying, there's no hard evidence to do it this or this or this way. And the question to Mendel was, how do you select the kind of music that you would optimally use in a session? What's your decision tree look like, or what makes you choose? Can you maybe explain a little bit more about what you develop for those who have not heard you talk earlier?
Sure. Yeah. So my research started at Imperial College London, where I had this aha moment at some point, looking at an image from, I think it was Johns Hopkins University, seeing a patient lying on a couch, listening to music with eye masks, and realizing that music is almost the only external stimulus during the entire duration of these sessions, these psychedelic therapy sessions at least. It's a very important contextual variable. So a lot of my research focused on understanding the role of music and how music and psychedelics interact with each other, how they work together in the brain, and how we can leverage the therapeutic effects of music, and how we can make better decisions in selecting music to support patients in better ways. Now, there's a lot more to say. I mean, for those who didn't attend my opening talk this morning at 8 a.m. my time, I always emphasize that it's not just about the music when we think about these therapeutic paradigms. I talked about what I refer to as the synergistic core. You have the set and setting, you have the drug, but you also have the interpersonal element, the psychotherapeutic relationship that already begins before the sessions happen. And then there's music being played. And even for music, it's not a black and white thing. I would argue that there are very good case studies or good cases, good examples for patients that would actually be better off without music, for example. Now, not to make things too complex, to get to your questions about selecting music for patients. I get this question quite a lot, and I think I am really good at systematically disappointing people by not giving a very clear answer. It's
at least it's systematic.
Yeah, well, I'm less and less interested in talking about genres of music, for example, and I'm more and more interested in understanding the variables in sound and music and how they create different supportive conditions. And what kind of supportive conditions are needed really depends on where the patient is in his or her journey. which is a very dynamic and unpredictable component. So the question is really constantly to inject a term by Carl Rogers. How can we design a growth promoting environment? How can we create an environment where the patient can connect with his or herself in a more constructive and new way? So when it comes to the music selection, I very often start by emphasizing these elements, that you really need to start with the person. And the person that enters this session has his own, her own story, and his or her own musical language, his or her own inclinations of responding to music in a certain way. So to make it more concrete, if I would be listening to classical music my entire life, and suddenly I hear a psychedelic therapy session with, in a psychedelic therapy session with primarily electronic ambient music, it's almost the same, I would argue, as having talk therapy with someone that speaks Chinese, whereas I'm Dutch. Music is a non-verbal language, and it's not universal in the sense that everyone understands the same language. It's informed by our upbringing, our culture, and so forth and so on. So that personal element is very important to take into account. And then secondly, you have all the other variables there. You have the pharmacodynamics of the drug. So kind of really from a super high level, you could think about the pre-onset before the medicine is given, the onset when there's the medicine is provided, but the patient is waiting for the effects to kick in, building towards the peak, and then a return to normal consciousness. Helen Bonny, for example, and others did some really good work on this front already, Stan Groff as well, looking at these different phases. And you could argue that these phases have already certain specific therapeutic functions attached to them. For example, in the early phases, you don't want to bombard people with emotionally evocative music. One of the primary therapeutic functions in that moment is to provide a climate of reassurance in order for the patient to feel calm, safe, and increase the capacity for the person to be opening up for the unfolding process that follows. It's during peak where usually therapists will play more emotionally engaging music. And what kind of music that is really depends on what may be needed in that moment, or what is presenting itself. But typically, the primary function of music is to deepen certain psychotherapeutic processes that are unfolding, or certain feeling states that are unfolding, and allowing them to surface. And the degree to which you want that as a therapist, you want to have control over that really much depends as well, again, on the patient variables, the ego strength of the patient, and so forth and so on. Yeah.
Okay, thank you very much.
Let you allow for just one short remark. So we might have quite a bit of a difference in between the two approaches, the psycholytic and psychedelic approach in that respect. So my personal opinion is, from my limited experience, is that the music is much more important in the psychedelic approach than in the psycholytic approach. And some psycholytic therapists have used mild music in the background, and some don't even.
I was listening to you talk, Torsten, and I was kind of comically and tragically reminded of the fact that Europeans developed this very sophisticated psychotherapeutically, psychodynamically informed approach, and then the Americans came along and decided to bomb the hell out of the ego, and it's high dosages. But it's just actually a good point. So one of the original intentions of music in these high dose approaches, the psychedelic approaches, one of the functions is to provide, in my own words, paraphrasing Helen Bonny and others, to provide structure in the absence of structure, or in your language that you used, Torsten, when you differentiate between the continuous and the fragmented states, to make sure that the patient is less in this disintegrated state and there's a sense of movement and structure. Yeah. So
you kind of help him structure the potentially fragmented way of experiencing, right? By supporting it with music and help it structure in a way that he's not really losing the coherence.
Yeah, and the opposite may be the case as well. When a person has high resistance to immerse and to loosen up, open, you may actually do opposite with music.
Yeah.
Okay, very interesting discussion. It also speaks to the training of therapists. Peter, there were a number of questions on what an optimal therapist training should involve. Could you enlighten us on that, please?
Yes, a very important and also very long question. Maybe another lecture for an hour for that question.
Yeah, I'm sorry.
I think at the moment we now do in Switzerland a 3 years training, and we want to give away other experiences over decades, but we learn that maybe 3 years is too long of a training, so we cannot train enough therapists. I think there is a growing need for trained people for all the studies that are running, and after the studies maybe also for the treatments going on. So the training should be not too long, and I think it should consist, of course, of the theoretical background on neurobiology and psychology models, and just what was mentioned by Katrin, that we need to know also what kind of therapy fits to this, what interventions fit to that, what we do. It's now it's a black box what we are doing. We are doing, yes, we play music, we sometimes we touch the patients if needed, but in some it is a black box. So I think we should talk about what we are doing and why we are doing what we are doing. This should be part of a training. And then, I mean, the most crucial thing is if these trainees need to have self-experiences of the substances or not. You mentioned compass pathways. They decided, of course, to have a training without that, also because of legal reasons. But we are convinced that we should include a kind of personal experience. We can do it with ketamine, but I think ketamine is quite different from psilocybin and LSD, and it's not sufficient to do a ketamine or holotropic breathwork experience and to say it's basically similar or close to what people experience on psilocybin or LSD or MDMA. So we are fighting for this, and I think, yes, the neurobiological background, the scientific background, the psychological framing, and the self-experience, these three parts should be in a training. And I would prefer to do a training of, I would say, 18 months or something like that, that we can train a certain number of patients, of therapists the next years.
And would you say that people, I would be tempted to say that people would need a regular psychotherapy training and on top learn to work with psychedelics.
Yeah.
Do you agree, or would you
Yes.
say just the psychedelic venue is enough?
No, that's just what we said. People who come to our training, they should have a basic training in some other method. They should not be beginners in psychotherapy. So they should have some experience in psychotherapeutic training. And what we do is in addition to that. And I think what is very important besides of training, people then should continue in doing intervision and supervision, basically also intervision, to discuss what they experience. I think it is the more experience to have in guidance and also in self-experience, the better you can talk with other people what we are doing and what is best to do. And so I think it should be, of course, a continuous kind of training that will just then go on when the formal training of 18 months is finished.
Okay, thank you. That's very, sorry.
Yeah, can I contribute just a little bit? So in the 1960s, Leuner and Sanderson and others have founded the European Psycholytic Society, and they have also kind of established some standards about that. I just will give you a very short idea, which is 5 self-experiences per therapist. It was an obligation in their eyes. And then they had the minimum standard of treating 5 patients that way that an experienced therapist is treating somebody and you sit in the corner assisting and looking at what he's doing, and then you change that for another 5 sessions. So the The experienced one will sit in the corner and the other one will be on the patient, and then you can discuss and supervise that afterwards. This was the minimum approach. And by the way, Hans-Karl Leuner, who has led that society in these years and was a leading capacity in that field, has already designed a kind of training schedule in respect to these practical aspects, which I have in my personal belongings, and will be published on the ISSP website soon, so that we can get an idea what these guys have gained out of their experience. But in general, there is, with the ZEP Society right now, I'm involved with that training too, we have a very fine-grained curriculum what has to be treated as topics during the theoretical education.
Okay, great. Thank you very much for this addition. And it would be very interesting to exchange these ideas about training and see if we can develop a framework that most people would trust as a good training module. We have 4 more minutes. Peter, there's one question that has. Well, there's several questions. We cannot address all the questions. I think people can also email the speakers directly or use the app to contact the speakers directly. That's most probably better. There's one question on what to do with patients with severe personality disease, attachment trauma, who are less likely to trust the therapist and the therapeutic situation. Do you see a possible role for psychedelics?
Yes, I do see that. And interestingly, there is a team in Basel. They want to try to treat prisoners with LSD. I mean, I discouraged this idea a little bit, but I mean, they are interested to what extent is it possible to treat people with severe psychopathological disorders. And you mentioned trust. I think we as therapists should not enter to a psychedelic or psycholytic session without having a basic trust into the patient. This is on both sides. I mean, the other thing is obvious. If the patient does not trust us, maybe he will not come. But if they come, we have to build up a relationship that is based on mutual trust, which I could be confident that then when it will become difficult, that the patient will listen to me. And we have to have an agreement on that. On that, you have to listen to me, and we end the session together. You must not go home before everything has ended. And I think there are patients who are not able to build up a relationship that is stable enough for that. And there is a contraindication, in my opinion, to treat them, because it's a danger not only for the patient, it's also a danger for us and for the method.
One problem with that approach is, to my eyes, right now in this historical moment, I wouldn't go for the most complicated patients with a new kind of approach. So I would recommend to use the more conventional formats, if I can say that, first off, and then if we gather experience enough, then we can expand the spectrum. But don't go right now with these minimum experience for the most hardest diagnosis, and especially attachment disorders might present serious problems potentially. And if we have a lot of experience and very well educated therapists, we might go on for that later on.
Thank you for these wise concluding words, both of you. I fully agree. I couldn't agree more. Thanks to Peter, Katrien, and Torsten, and also Mendel for your wonderful presentations and discussion. And I give the word back to Joost, who will make some last announcement.
Yes, thanks to you, Robert.
And pleased to meet.
Same for us.
Yeah, thank you very much, Robert. And thank you all for a discussion that actually made me feel like you're in a panel together. It's wonderful to see you responding to each other and to get some sense of connection, because it is a little bit different sitting behind your computer. And I really look forward to seeing you again over the coming days. So thank you very much. Thank you very much, Robert, also for moderating this discussion so expertly. And to all the attendees, I would just like to announce that we have a 1 hour break now, but to keep you engaged, we also have a live music session that will take place here in our headquarters, but upstairs. So if you go to the agenda in the break, there will be another link to a live stream. The next time you see me, after you click that link in a couple of minutes, we're just setting up right now. You'll see me in a different room. I'll introduce the musician, and you can listen or watch, listen to or watch the music while you get your much needed coffee, sandwiches, break, whatever you need. Please go away from the computer, but don't forget to listen to the music. Thank you very much, everybody, and I will see you back there, and afterwards we start again at 2.
Okay, thank you very much, Joost. Bye-bye.